So welcome everybody to this roundtable discussion. I am chair of the Department of Neurosurgery, and I have a great select audience here that's going to talk about spinal tumors today. As we all know, it's a really complicated subject, which I personally enjoy as well. So, Sean?
Yeah, I'm Sean Barber. I'm one of the spine neurosurgeons here at Methodist. I have a specialty in spine tumors.
Paul?
Hi, I'm Paul Holman. I'm the chair of spinal neurosurgery, and really looking forward to this talk. There's a lot of continuity in the room. Ziya was my mentor when I was a resident working at MD Anderson, and then Sean came through our program, and we delivered him to Ziya for a fellowship at Brown, so things are coming full circle today.
And Ziya, do you want to introduce yourself as well before we go
further? Sure. My name is Ziya Gokaslan. I am the chair of the Department of Neurosurgery at the Roundtable Medical School of Brown University and chief of neurosurgery at Brown University Health. I have had the pleasure of spending a lot of time at Methodist Hospital as a part of my residency training, at the time as a part of Baylor College of Medicine. So it's a great institution. It's wonderful to be back at my alma mater virtually. So, and I also both Sean Barber as well as Paul Holman are great friends and wonderful colleagues, and it's wonderful to be able to discuss some of the cases together tonight.
And Ziya, thanks very much for joining us, one of the world leaders in spinal oncology. It's a real pleasure to have you here today. Great. So what we're going to do today is going to be largely case discussion. So this must be an informal discussion. We'll present and we'll all give ideas of how we'll approach this case. So I think Sean's got 3 cases to show and Paul's got 1. So Sean, do you want to start the cases and let's go?
Sure. So this is the first case. This is a 55-year-old male with no medical history, very healthy guy who just came in with back pain and had an MRI that showed what you see here. So we see this L4 intraosseous mass with enhancement. There's some central canal stenosis. He really has a normal neurological exam, no weakness or other deficit, and he had a biopsy by radiology that showed chordoma on pathology. So
Paul and Ziya, how would you, obviously this is Sean's case, so he knows the case well.
I think it's Sean nicely alluded that they proceeded with the biopsy in a patient who doesn't really have any history of cancer, that is an isolated spinal lesion. It's the sort of the next right step to take so that you can establish the diagnosis, because depending upon the diagnosis, the treatment is going to be quite variable, and also some of the things that you may have to do prior to the surgical procedure may be very different. So I think the biopsy is exactly the right next step.
So Ziya, the only question I have, so what about seeding the tumor cells with a chordoma? Because obviously chordoma is a curable disease. And if I'm doing something with the skull base, upper spine, I want to try and get it all out. What is the risk of seeding with a needle?
Yeah, it is certainly a concern, particularly with chordoma, that tends to seed the soft tissue very easily. Fortunately, nowadays, the biopsies are done using so-called dual needle technique. There's an inner needle and there's an outer cannula. And so the outer cannula is really passed by the radiologist, and it's docked right on the pedicle of the vertebra of interest, and then the inner needle is passed through that. And that sort of protects the tissue as the sample is pulled out of the vertebra. And in some cases, we also do a small vertebroplasty to close the hole where the biopsy is taken from the pedicle, and that sort of minimizes the risk of seeding. I think in the old days, when the people just approached this with a single needle without paying attention to some of these details, I think the seeding risk was much higher. Fortunately, it's much less nowadays.
Paul, any comments?
No, I think the points that Ziya brought up about the needle biopsy are certainly relevant, and obviously you have one chance to do this right and get an en bloc resection. So point well taken.
But Ziya, the question I'm going to be the devil's advocate in today's meeting. So obviously, to me, I look at this as a surgical lesion. Is the biopsy going to change your approach significantly? I mean, what did you think? Did you think it was a chordoma before, Sean?
We thought it was, yeah, but there's other pathologies that you wouldn't, put the patient through an en bloc spondylectomy for, There's some maybe that would be radiosensitive or osteosarcoma, or I mean, there's others that you might consider systemic therapy first or
So yeah, so
radiotherapy.
what percentage of your spinal tumors like this would you biopsy first versus going in straight in and operate?
100% of the time, particularly if the surgical procedure that you're proposing is an en bloc resection. It's a very morbid procedure that has significant complications and risk profile. So for a situation like this, we would always do the biopsy. As Sean articulated, the biopsy can reveal, the tumors can look very similar on MRI. For example, you can get a multiple myeloma or plasmacytoma diagnosis, which could potentially be treated with radiation or systemic treatment. You can get a diagnosis of a metastatic renal cell carcinoma that may have to be embolized before any kind of surgical procedure. And a diagnosis of an osteogenic sarcoma, for example, those patients are best treated with preoperative chemotherapy and then surgical resection to control the micrometastases and systemic disease. So there are multiple reasons why one should really obtain a biopsy prior to proceeding with the
So
surgical
Paul, in
intervention.
your practice, do you get biopsies in 100% of the tumor patients?
Yes.
Oh, you do as well. Okay.
I mean, I think unless you have a patient that's presenting to you with a known, primary with other metastases, obviously you would probably do a basic metastatic workup in this patient, CT scan of the chest, abdomen, pelvis, and MRI scan of the other regions of the spine.
Okay.
If they have known metastatic disease within the last 6 months to a year, then it can be, I think, presumed to be a metastasis from that primary. But if it's been several years since a previous remission or can be thought to be a new diagnosis. In this case, he had no history of cancer. Also, intradural tumors definitely, wouldn't biopsy typically, but
Yeah, we talk about these.
but these intraosseous tumors, yeah, usually.
So how did you manage it, Sean?
Well, the goal for chordoma, as you know, is not really responsive that much to radiotherapy or chemotherapy, so it's really a surgical disease. So the goal is en bloc resection, which in this case would be a spondylectomy or L4 spondylectomy. The tumor, it's maybe hard to see, but actually stretches a little bit into
So obviously, Sean, there's going to be some layman. Yeah. So can you explain what a spondylectomy is?
Yeah, it means removing, en bloc resection is removing the whole tumor in one piece. And in this case, spondylectomy means removing the parts of that vertebral body or the parts of the spine that have tumor involvement all in one piece, which may be the vertebral body alone or the vertebral body plus some of the posterior elements like a pedicle or a transverse process or what have you. But in this case, it was mostly the vertebral body that was involved. So the goal was removing that all in one piece without entering the tumor capsule or seeding the tumor into the operative bed.
So tell me how you exactly did it.
Well, it was a two-staged approach. So we did a posterior approach first. I stole this picture from you, Dr. Gokaslan. I'm sorry, from one of your publications, but it's a posterior approach first where we did instrumentation. So we did pedicle screws and rods above and below this tumor, and then did a laminectomy and kind of exposed the dura and also skeletonized the nerve roots out left and right. And I think there are different ways it can be approached from the front, but in this case I used Tomita saws, which are sort of actually going out of style, I think, are difficult to find nowadays. But a Tomita saw is like a diamond wire saw that you can pass from the back to the front and then retrieve the saw ends from the front in order to complete the discectomy or vertebrectomy. So that's what we did. I have a video of the back portion. This is us. You can see the dura is exposed and the nerve roots are sort of skeletonized here, and we're passing a coiled up portion of the Tomita saw kind of in between the psoas muscle and the lateral aspect of the vertebral body, which will then retrieve later from an anterior approach, the retroperineal approach. This is a picture from the front. We've retrieved the saw ends and are just pulling it through to complete the discectomy there.
Paul, any comments on this case?
No, I mean, I think this is the technique that we learned from Ziya. And I'd be interested to know, Ziya, if you've modified this at all. I mean, obviously there's things like the bone scalpel now, some unique ultrasonic bone cutting tools that you can use in a more blind fashion without worrying about getting a dural tear. So I'd be interested to hear your comments on any technical modifications.
Yeah, for cutting through the disc, we still use a tomato saw. I think it still works the best, and it ensures that all the attachments have been disconnected. As you know, the annulus is very tough, and it may be very difficult to remove the vertebra if any little piece is left behind. So saw allows you to know for sure that the annulus has been circumferentially disconnected. As you indicated, if you're cutting through the mid vertebra, for example, you're going to remove half of the vertebra above and below. In those cases, you can cut through the middle of the bone using either tomato saw or bone scalpel. And in some cases, we even use a diamond burr cutting through a trough to remove the half of the vertebra and reconstruct the remaining defect with a variety of techniques. But tomato saw still is a gold standard for cutting through the disc.
So Ziya, the question I have for you as well is, what about margins in the OR? So what do you think of getting operative margins for the chordoma when you're doing this on-block resection?
Operative modules meaning?
Pathology, intraoperative pathology to make sure you...
So the pathology in a lot of the bone tumors can be deceiving. First of all, in many cases, the pathologist would have to decalcify the tissue in order to look at the subcomponent of the tumor to make the diagnosis. And so I think it is difficult to rely on a frozen section diagnosis given to you by a pathologist in the OR on a bone tumor. And that's why it becomes even more important to know before the operation what the pathology is. We typically don't get a frozen section and send the specimen for permanent results.
And then what about post-op intraoperative imaging, such as an intraoperative CT, to make sure you really got it?
Oh yeah, so that is crucial. I think it makes the life so much easier for us. We have intraoperative CT scanner, image-guided navigation systems. We also, not uncommonly, map the tumor on the pre-op MRI fused with an intraoperative image, and that it allows you to be very precise and remain outside the tumor throughout the procedure. And so for those tools really made the operation much simpler and much more precise now. So it's key to have those in the OR now.
What do you think about that, Paul?
Yeah, I mean, I think obviously intraoperative navigation has been a game changer in many of the things that we do in complex spine surgery. And this is, I'm sure we're going to be talking about some sacral cases as well. I think that's probably the best example. But so for the tumor fusion, are you guys using Brainlab for that, Ziya?
We currently use the Brainlab Curve image-guided navigation system and their software to map the tumor. And then we have an Aero intraoperative CT scanner, which unfortunately, as you know, it's coming to the end of its life. But it's a diagnostic quality CT in the OR, and it really has been incredibly helpful.
Well, that's my question. You want to have a diagnostic. Obviously, navigation is one thing, but navigation is off sometimes. I don't care in whose hands. You're going to be off 4 or 5 millimeters sometimes. And if you want to get a complete resection of the chordoma, you cannot have 5 millimeters on each side. So I agree, Ziya. Intraoperative CT scan. I mean, intraoperative OR. Sean, what do you think?
Yeah, I agree with you. But I actually, another question, traditionally surgical oncologists will ink the edge of a tumor if there's a concern for
soft tissue involved.
Soft tissue or a margin at risk that will be examined by the pathologist. We don't typically do that though. Is that right? I remember in training.
No, we don't. I think the best you can do with these tumors is going to be marginal margins. In some areas you can get wide margins, but on the epidural side, typically the tumor capsule is very thin. It comes under the dura. It's abutting the dura. Those margins are going to be marginal. But in our experience, it's rare to get any recurrence on the dural side if you are able to stay outside the thin capsule of the tumor.
Mm-hmm.
So yeah, this is a political question which you may or may not want to answer. The thing about chordomas and certain diseases, if you do it wrong, particularly in a young patient, that patient's going to have a worse outcome. So what do you find in your practice when you go to people getting a surgeon that doesn't do this all the time operating, then you have to go redo his problems, or her problems, and that's we see here often, people, and I think someone like a tumor like a chordoma, you've got one shot to really get this thing cured, and I think that sometimes people will do a inadequate operation based on not having the experience as a surgeon. I mean, what's your experience? How many second opinions do you get from people that have had a non-ideal operation for a chordoma, regardless where it is in the head, or the spine?
Yeah, I mean, it's hard to be hypercritical of the surgeons who are in the front line and seeing these patients. Some of the patients have significant epidural disease, and they may have neurological deficits, and they feel pressure to operate on the patient. In those cases, we try to do the best we can to get the definitive procedure under those circumstances, and many of those cases are going to require postoperative radiation treatment to deal with the microscopic disease. I hate to be critical of a surgeon who is dealing with an emergency situation in the ER and making critical decisions. And everything is easier in hindsight, as you know. So,
Sean?
I mean, the first surgery is the most important, I think, in terms of prognosis, but even in experienced hands, chordoma is, some of these cases are very challenging, and even in the most experienced hands, there's risk of tumor capsule violation. And yeah, even in case where it's resected en bloc, these tumors are difficult to treat. They recur, unfortunately, even in cases of en bloc resection. Is that not true, Dr. Gokaslan? For chordoma, recurrence is unfortunately inevitable in most cases.
Paul, what's your opinion?
Even in certain tumors, we go back and remove the tumor as best as we can if there is residual tumor left based on the MRI. And if there's hardware, we sometimes remove the entire tumor along with the hardware that's put in there during the first surgical procedure. So try to do the best operation you can, knowing that the margins are going to most likely be positive microscopically, and you have to fall back on the post-op radiation to take care of that.
Paul, comments?
No, 100% agree.
Okay. Any more in this case?
This last slide is just kind of the final removal of the tumor specimen en bloc, from the front, which was, he did get post-operative SBRT, and we have some post-operative imaging. We did use carbon fiber screws and a carbon fiber expandable cage, and he actually had rod fracture several years later, which we had to revise. But and I had spoken to Dr. Gokaslan about the problem of pseudoarthrosis and spine tumor cases where you can't use BMP, you can't use typically autograft, so that's another challenge sometimes. But
hey, Ziya, I have a question for you. Obviously, I do a lot of deformity surgery, and there's been obviously a big trend. I mean, Sean used 3 rods in this case, and I'm not sure where it fractured. Are you routinely, for one of these lower lumbar spondylectomies, using 4 points of fixation and 4 rods now?
Yes, that's what we moved on to nowadays based on our experience of rods fracturing down the line as well. And we also use a fibula strut graft that's split in half to span the laminectomy defect dorsally, because there's no bone to be put in there, so that at least provides. And I know some of my colleagues are using vascularized fibula to augment diffusion both anteriorly as well as posteriorly, and they tend to work quite well. It lengthens the procedures and adds some morbidity, but I think diffusion rates are very good. And so I think with these cases, thinking about fusion is important, because these patients are going to be around for a long time and need to be prepared for rod fractures. And 4 points of fixation, quad rods, sometimes using cobalt chromium rods can be an adjunct to try to minimize the risk.
So Sean, why would you not do that? Anterior column is gone, as Ziya is talking about. So why would you not do an anterior fusion as well, anterior plate?
We did. You just can't see the implant. It's a carbon fiber expandable cage.
Carbon.
So there is.
Okay.
Yeah, you can see but there's an implant there. Yeah.
Okay.
Yeah, so the carbon fiber cages and carbon fiber implants are also very helpful in this situation because you're going to give post-op radiation, particularly proton beam. Radiation planning is much easier, and the hardware doesn't interfere as much with the radiation delivery, so dosimetry can be more precise. So our radiation oncology colleagues definitely prefer carbon fiber implants. They are a little more difficult to use in the OR, as you know, and also quite expensive as implants.
Ziya, are you doing any structural grafting of tall discs in this case? Obviously, probably the weakest point is the L5-S1 disc. Have you done or had any follow up on whether or not grafting some of those levels is worthwhile from a structural perspective? Because you're already you did the big anterior exposure, and the 5-1 disc is just sitting in front of your face.
It's a good question. I don't think it has been really studied very well. I don't do that. And one of the reasons I don't do it, I don't want to weaken the foundation where we're going to put cage and other things. And posteriorly, it's an area that we can better fuse, right? The L5-S1, at least we maybe have some bone and connect it to the sacrum a little easier. But whether or not doing a inner body anteriorly at the level above and below, if you're going to incorporate them in your fusion. But the problem is not really the levels above and below. The problem is the area where you took the vertebral body out and you have a pseudounion because the bone didn't heal through the cage. And so I'm not sure if you're going to solve the problem. But I don't think we have really studied that well to know the answer to the question.
So Sean, sorry, one question. So I read your slide. There's a local recurrence 3 years later.
Yeah.
Where did it recur? Which part of the spine?
Right outside of the field. So this is at like L2.
So way above
L3, right above.
You went L4, so you went to recur all the L2.
Yeah, right above the prior resection. I don't remember the exact spot. It was between the psoas and the vertebral body.
And what is the mechanism of that? The bathyplex plexus or venous?
Well, it could have been a capsule violation during surgery. I don't know. I mean, the margins seemed perfectly.
But where was the tumor? Was it epidural or was it in the bone itself?
It was anterior in the retroperitoneal space.
Wow.
Yeah.
So Paul, how could that, if you get in seeding from an L4 and it's not epidural, not going by the venous plexus, and it's going anterior to the body, how would it get there? Because you've got to think about these things. If you want to prevent and push the disease further, you should be thinking, well, how could that reoccur L2 anterior? Ziya, any thoughts on that?
Yeah, I think there are a couple of different ideas how that might happen. One is spread of the disease through the venous plexus up and down, microscopic. You don't really see that. I think in the cervical spine, we do see that quite often. You have a disease at, C4 vertebra, for example, and you see microscopic beating of the tumor along the longus colli, 2-3 levels below the area of the surgery. So that's sort of explainable. Sometimes they spread through the vertebral artery along the perivertebral plexus. And so some of it can be venous spread, some of it can be capsule violation with microimplantation of the tumor during the surgical resection. Sometimes the tumor spreads through the ligaments, under the ligaments, anterior longitudinal or posterior longitudinal ligament. And then other thing to think about, if the tumor is within the substance of the vertebra, a few levels above and below, some of these patients have multiple areas of notochordal rests in addition to one area of a tumor. And so those additional sites may turn into chordomas down the line, and they may look like recurrences, but actually is a new site of disease that formed in the setting of a notochordal rest. So those patients where we have other spots that we notice on screening MRI, we follow them periodically to make sure that that's not the case. And if you see any enlargement, you can go ahead and stereotactically radiosurgerize those areas and can be quite effective in controlling.
Yeah, so just one question would be, if you think there's going to be microscopic disease, MRI negative, when you do your pedicle screws, say you go 2 levels above, 2 levels below, why not, while you're there, take a sample, send it not to frozen, but send pathology, just see what it shows over time. Because I think, you as you said, you may find disease there that's MRI negative. And
some patients have white little hyper intense signal on T2 weighted images, although cortical architecture of the bone may look fine on CAT scan. So those are quite consistent with notochordal rest. And we have done a few patients where we did a terrifying biopsy of those white spots, and they do show notochordal cells, not by definition a chordoma, but notochordal cells suggestive of an island of a notochordal rest, which can lead to formation of a chordoma down the line. If you get a random biopsy through the pedicle, you may have a lower chance of hitting them. But if you see them on the MRI, you can really target them precisely.
But that'll change your approach. If you're going to find abnormal signal abnormality, you're going to tell the patient your chance of a gross total resection is 0. But I think, Sean, for the, me and Ziya are old already. We, and Paul, something like yourself could be as you do them, just get a biopsy and see what the utility is. You never know. You don't look, you don't answer questions.
You can, and if your biopsy shows the chordoma cells, then obviously subjecting the patient to a major surgical procedure may not be necessary, but most of the time, by that time, the tumor is out and you're putting the pedicle screw, so it may be a little...
No, but even to push the field further, what you may want to do, say your MRI is negative, your CT scan is negative, you do your pedicle, and you'll get your pathology 6 weeks later after they decalcify, you may want to then increase your range of radiation. Say, well, we're going to radiate L4 in this case, but we may want to do 2 above, 2 below. So I think it's something that, as a nerd, I would do.
Yeah. Who was it, Danny, that would biopsy GBM or found GBM cells on the opposite side of the brain from where the GBM was located? Yeah. You never know.
To think about.
Yeah.
Well, that's a great discussion. Let's start with the next case.
Okay. This is a 74-year-old lady with no significant history. She just presented with lower back pain and kind of bilateral leg pain, and she's found to have this sacral mass, which was biopsied at another hospital and shown to be chordoma.
So Paul, you're going to start this one. What do you think?
Yeah, obviously, the kind of general workup and approach is similar to the last case with regards to knowing the pathology and obviously planning for MLUC resection. One of the things about this particular type of tumor as opposed to the last, obviously doing the anterior exposure, I'm assuming you worked with Dr. Reardon, one of our vascular surgeons here. But I think the thing that Ziya has really shown everyone in terms of managing these, I remember as a resident at MD Anderson, CSF leak was a big problem with managing these particular chordomas. And so having a team, which would include plastic surgery, general surgery, you talked about doing these cases in the community. I don't think anyone would attack something like this. Obviously, this is a different animal than something that's more manageable by an average spine surgeon. But I think the real key to this particular case is having that team-orientated approach, having the right people that have the experience. Plastics, general surgery, obviously the spine team as well.
Ziya, any comments before we let Sean carry on?
I 100% agree with Paul. I think it's a multidisciplinary team is a key here. Some of the tumors can be removed all from posteriorly, particularly if it's below the S2-3 region, and some of them require both anterior and posterior approach. Having colorectal surgeons in the OR, even if you're doing all posterior surgery, is critical to make sure that the rectum is intact at the end of the case after the tumor is removed, because the best time to repair any type of injury to the rectum is the first time around. Finding a leak later is really quite catastrophic for the patient. CSF leak can be a problem if the tumor is above the S2 level. And so you need to be prepared to deal with that. And sometimes can be formidable. But plastic surgery is sine qua non with these cases. I think they are the ones who can help you close these large defects and minimize the risk of wound complications. So despite all of this, wound complications and infection rates are quite high in this location, given the proximity to rectum and the bacterial colonization rate in this location. But these are potentially curable tumors, and the best operation is the first operation that you can do.
Sean, how did you do it?
We did do an anterior approach initially just to make sure the rectum and other retroperitoneal contents were kind of separate from the tumor. But I think after speaking with Dr. Gokaslan later, would have been reasonable to do it posterior alone. But in this case, it's kind of at the S2-3 junction is the highest or most cranial portion of the tumor. So one question I think in these sacrectomy patients is whether instrumentation is going to be required. So in this case, it was not, which at least from what I've learned is because the SI joints were not, compromised or didn't compromise from the surgery. Is that your typical approach?
Yeah, I agree with you. And so if you're below the SI joints and the sacroiliac ligaments are left intact, typically instrumentation would not be necessary. If you're above that area, I think that we have a lower threshold now to instrument these people. And mainly because of the fact that they end up getting stress fractures, particularly if they do get postoperative proton beam or stereotactic surgery to the area, most of the time proton beam. And those patients have a higher rate of stress fractures or radiation-induced fractures. And so if it is above the SI joints, we instrument them, do a lumbar pelvic fixation, typically try to keep it short from L4 down. That can eliminate the risk of problems associated with the stress fractures.
So Sean, how did you do it for the lay people? Explain what you did.
Well, we did an anterior approach first just to sort of separate the rectum and everything from the tumor, and then did most of the tumor resection posteriorly. You can see in red here kind of the cuts that were made. It's first just kind of a laminectomy above the area of tumor to expose the dura, and then you really ligate the thecal sac kind of proximal to the tumor, to the cuts you're going to make. And then you cut through the sacrum. We used, I think, a bone scalpel and drills in this case, cranial to the tumor, making sure there's wide kind of margin of healthy tissue there. And then more ventrally and distally, there's a lot of ligaments, sacroiliac ligaments that need to be ligated, and then the rectum and everything need to be separated carefully from the tumor, and it can be removed in one piece. I think you can see this the very end of us here, removing that final ligament, removing the tumor, and you can see deep there is the rectum and other retroperitoneal contents there. But Dr. Gokaslan, when do you use an anterior posterior combined approach versus just posterior alone? What are your major criteria there?
Yeah, so the anterior approach I think is necessary if you are dealing particularly with the vessels, the anterior iliac vessels. They tend to cross the sacrum at the S1 levels laterally, and then right at the top of the S2s. And so if you're concerned about controlling those vessels, it's always a good idea to do the anterior approach first to separate the rectum and sigmoid colon, and also controls those vessels and ligate them so that you wouldn't enter them from the back. If you do, you can lose a lot of blood, and you can lose the patient in the OR table. And so that's one reason. If you are going to harvest the mycocutaneous rectus flap to use to close the defect, in those cases, since you're going to be in the front, you might as well separate the rectum, put something in front of it, of the sacrum, between the rectum and the sacrum, so that you can protect the structures. But the higher the tumor is more likely that you're going to need an anterior approach. Higher the tumor, the defect size is larger. More likely you're going to need the myocutaneous rectus flap, pull-through flap to be able to close the defect. So that is when the anterior approach is necessary. If you're going to do a total sacrectomy, obviously L5S1 disc needs to be disconnected. In order to do that and control the vessels in the front, you always have to do a two-stage surgery, first from the front, then from the back, to remove the tumor.
Yeah.
So Sean, how did you deal with a CSF leak?
We didn't actually have a CSF leak in this case, thankfully. Yeah.
And how would you? What do you do to prevent?
Yeah, so it
my
could be a really
question.
nightmare. It could be a really nightmare in this situation, and not with this case because this is a little too low for that. But if you are up in the S2, S1 region, first of all, how do you ligate the thecal sac is important. We use two separate ligatures for that because one sometimes slip out. And then we also put a large vessel clip on top of that, so you cannot be too safe in that location. And the suture size is important. You want sort of a heavy silk suture, or you don't want a suture that is too thin because it cuts through the thecal sac and it opens up. But if you do get the CSF leak, it's best to take the time to repair it as best as you can with a running stitch, and then we typically use Duragen on top of that. And then nowadays we like using Tacoseal, which really is quite effective. I know you guys, skull-based surgeons, like that, and it really quite effective in sealing the skull base after endoscopic surgery and so forth. And then if you really are concerned about it, diverting the CSF with a lumbar drain is a key. And then finally, in desperate situations where you end up with a big pseudomeningocele and you cannot really control it, sometimes we resorted to the lumbar drains to divert the CSF permanently. And so the things can get quite desperate depending upon the complexity of the situation. It's best to avoid the CSF leak at all costs. That's the best solution.
And I think the best way to get the suture slipping in any general surgery is doing a suture leg, where you actually suture first and then you do your wrap and then you do your tie. I think if you just tie anything that's going to slip over time, I think that's something I learned as a general surgeon, using something called suture leg, be it an appendix or bowel. You first tack it and then you do your suture and then you tie it, and I think that prevents the slipping. But I agree, in these situations, I mean, you want it to be completely intact.
Sure. Yeah.
And then the other thing, when you're cutting the sac, transecting it, and make sure that you have a little bit of a cuff left, because if you cut too close to the suture, it's more likely to slip out.
Yeah, no. And Sean, the other issue is the bladder and bowel with these people. You take in some nerve roots. How do you manage that?
Yeah, I mean,
how do you counsel the patient first of all? Well, actually, let me Sean, Paul, when you do this, what do you tell the patient before? I'm taking your S2, S3 nerve roots. What do you tell them?
I mean, I think it's just the issue of telling them that there can be, those potential complications. Obviously, if you're doing something higher up, the patient's going to have issues with incontinence. So it's just about patient education.
So Ziya, how do you counsel patients? Because I mean, it's that's a big thing.
It's a huge issue for these patients, and I think we educate them about what's going to happen. Sometimes we are not very good at that. I typically connect them with one of our patients who had a similar operation and dealing with bowel and bladder issues. I think they are very helpful in educating the patient. If there are concerns socially about that, then we offer colostomy as an option. Colostomy allows you to control the stool in your privacy very effectively, and so you don't have to deal with some of the inconveniences that come with that in public setting. As far as the urinary incontinence is concerned, it's really inability to empty the bladder. You cannot really open up the urinary sphincter. And so that is managed typically with self-catheterization. If you're able to keep the two S2 nerve roots, many of these patients actually do quite well. If you keep two S2s and one S3, they are doing exceptionally well. And if you cut the S2 nerve roots, unfortunately, they are really rendered bowel and bladder incontinent with no voluntary control. Those are most challenging ones.
And you can imagine a CSF leak, incontinence, a nightmare.
What percentage of your patients, Ziya, do you opt to get a colostomy, would you say, when you have a
Yeah,
high tumor?
I would say that, I have been offering them more often than not. And because even in cases where I'm not sure if they're going to be able to manage it and offer it, the other advantage of the colostomy, to be honest with you, is by diverting the stool away from the surgical site, you can reduce your postoperative infection rate significantly. And if they're going to get post-op radiation, it's much more convenient with a colostomy because they don't have to deal with the radiation-induced colitis. So there are some advantages of offering the colostomy. And a handful of patients, we went back and they had pretty reasonable rectal sphincter. We took the colostomy down and restored the continuity. And so, later in my career, I am more liberal in offering colostomies to these patients, with the option of taking it down if we are convinced that they have reasonable function.
And disease-free. Sean?
Yeah. No, I mean, valid point. And then, have you ever had issues with like post-operative pain, like chronic pain, maybe like sacroiliitis in these kind of patients? Because I have at least one patient that I seem to develop like a sacroiliac joint dysfunction pain after partial sacrectomy. Is that it?
Yeah, I mean, I think there are multiple reasons some of these patients can get post-op pain. One is phantom pain they get by cutting the sacral roots. They do get phantom pain that usually goes away after 6 months or so. We manage those with gabapentin, Lyrica, medications of that sort. They're quite effective in controlling that. If you disrupt the sacroiliac joints, they can get sacroiliac joint-related pain. If they have significant pain, please suspect of stress fracture. It may be difficult to recognize that. So if you've really cut a significant portion of the sacrum, if they are highly active or you gave post-op radiation, you need to have a high index of suspicion for sacral fractures. CT scan is the best study to diagnose that. And sometimes you get a SPECT scan and other things to make sure that the hairline fractures can be recognized. So that could be a source of pain. And sometimes they have pain related to, soft tissue, resection, scarring, and neuromas and things of that nature. But it's not uncommon. Most of the time, the pain does resolve after 6 months, a year following the surgical procedure.
So Ziya, we as neurosurgeons deal with chronic pain all the time, and I don't know if you saw the most recent data about gabapentin and dementia and decline and problems with it. So it's something that even in my practice, I don't like prescribing pain medications, but it's definitely changed my outlook in regard to pain management. Has it changed your practice, that paper that came out that showed gabapentin has been associated with as you get older?
I think you're bringing up an excellent point. Previously, we didn't really know about it enough, and we didn't really appreciate that there could be long-term side effects of these medications, such as dementia. I think it is still an association rather than causation directly related to gabapentin, but there's definitely concerning data. And so we use it temporarily, and it's best to get off of those medications eventually. Maybe other options such as spinal cord stimulators or pumps with various medications may be a better option than being on a lifelong gabapentin or Lyric.
It's interesting because I've definitely had the conversation, and it's my older patients that know about this study. I think maybe the primary care doctors are really reaching out and trying to educate the patients that have been on it for peripheral neuropathy. Obviously, this is a very small subset of what a primary care doctor would be talking to patients that are taking these medications. For me, I tend to switch them to Cymbalta because a lot of the chronic pain, it's associated with depression. So you get the value of using an SSRI for both depression related to a medical problem, and then also it's neuropathic pain control. So we've had some good success switching patients to Cymbalta.
But Paul, the recent data shows the SRIs have exactly the same effect on cognition as well. Obviously I've got a cognition lab, I study cognition all the time, but a lot of that's been shown. So Ziya, I think what you said is probably appealing to me is the spinal cord stimulation. And none of the spine surgeons that just do spine want to hear that, but when you look at that recent paper that showed spinal stimulation for discogenic back pain, we diverging from the tumors now, but she actually had a better result than the discectomies and fusion. So the question is, so spinal cord stimulation, which is invasive now, which is becoming non-invasive and becoming better and better. I think that for some of these chronic patients, particularly you taking the S2 through the nerve roots, they can have neuropathic pain. I know myself, all I have is my brain. In my life, if I lose my brain, that's all I have in my life. It's only a good part of my life. And I think that if I would rather have a spinal cord stimulator myself, if I had something, God forbid, had something like this and I had neuropathic pain, I would go for what you recommend, a spinal cord stimulator, because the data's there that it makes a difference without the side effects of the drugs. And I think a lot of us, as neurosurgeons that deal with pain all the time, we must be thinking about that in the future, because I think no one understands how neuromodulation really works, but it works. When I look at vagal nerve stimulation for stroke recovery, it's just amazing how the field is changing. If you're going to have a disease, particularly young people, if someone's a young person, you want to be aggressive. Do the anterior, whatever, if it's touching the bell, get it out, do the colostomy, get them treated. They survive in 2 years' time, reconnect. What you got to lose? I think that I agree with you. I think that we need to think, sometimes be more aggressive, sometimes more is less, and less is more sometimes. I think that equation can flip both ways.
Yeah, agree.
Okay, Sean, next case.
Yeah, we're going to switch gears a little bit. This is intradural or extramedullary case. That's the third.
I should be doing one.
Yeah. Oh,
maybe.
Yeah. Okay, it's a young lady, 35 years old, no medical history. She just presented with some hand numbness and progressive weakness, her right arm, and was found to have this is at C12, kind of right intradural extramedullary mass with some ventral kind of spinal cord compression, also tracking sort of out the foramen there along the nerve root. Yeah, that's the case.
So before we get to Ziya, so Paul, what do you think of this case? What do you think it is? What would you do before we get?
Yeah, obviously, differential diagnosis here would be schwannoma and less likely a meningioma given its location and traveling out the foramen. So
I think it's highly likely, unlikely a meningioma.
Yeah.
Carry on. What would you do?
Well, I'll just wait till my case. So
Okay.
Oh yeah.
Never say never.
Okay.
Yeah.
Yeah, obviously, this would just be, an all posterior approach. I would look at the vertebral artery patency. Obviously, that's an important consideration for whether or not there's involvement and dominance of the vertebral. It's a young person, but a benign disease. So obviously, there would be pros and cons as to whether or not you would, sacrifice that for the a more complete, resection. So for me, those are kind of the big considerations going into surgery.
Ziya, any comments before Sean tells us how he does it?
Yeah, I agree everything Paul said. Occasionally, these tumors can look like this, and I've seen I see a lot of chordomas, so I do see chordomas that look like schwannomas as well. And so, but I agree with Paul. I think it's most likely a schwannoma. It's a typical location for it, and it's going out the foramen on the right side. Interestingly enough, I learned over the years that many of these tumors sometimes can be entirely extradural. They look quite ominous when you look at these images, and it looks like there's a large intradural component to that. And but I typically start out, with a laminectomy, come from a posterior approach, and start pulling the tumor out extradurally. And at some point we bring in the ultrasound and sometimes open the dura and look inside. Not infrequently some of these tumors are completely extradural, so you don't have to necessarily go inside the dura. But this one is probably brought into an extradural tumor, and it's safest to look inside the dura when you're pulling the tumor out.
So before we get
yeah, that's a great point, Ziya. I actually had a very similar case to this. It was a older retired Army surgeon, but it was a C56 foramen, and there was he had a lot of neuropathic arm pain. So I started extradural, and as we started kind of defining the anatomy, it was pretty evident that it was not intradural at all. It was completely extradural.
So Ziya, so before we had Sean, so how do you deal? Do you get a pre-op angiogram in these cases all the time, or not? Just rely on CTAs?
No, I do not. I do a CT angio if needed to see where the vertebral artery is to stay out of it. and these tumors can peel off the vertebral artery easily. Image-guided navigation can help you a great deal in the OR. You're not going to use any instrumentation or anything here, but in terms of knowing exactly where the wart is, you can use a CUSA to debulk the tumor internally and start peeling off from the surrounding structures. Almost always you can peel this off the vertebral artery without really causing any significant damage. C2 nerve will be taken both proximally and distally to resect this tumor completely. And if the patient is on the older side, you can leave a little tumor extradurally around the vertebral artery. You don't have to be very aggressive.
So Ziya, so I do quite a few of these because it approaches the area.
Yeah.
And for me is that I agree with you, there are a lot of them intradurally. But the issue is, it depends on the consistency of the tumor. So, and for that vertebral artery, and I've got actually one of our nurses that works here, and I've had to do it twice, and it recurred within 2 or 3 years. But hers obviously went more anterior, and it was like fibrous. It was completely fibrous. I found the vert, but it was very hard to get from normal to abnormal. And I mean, I just went as close as I could. But I think for me, obviously, when I do them, I will get an angio. And the reason being, the CTA is going to give you a great idea where the vertebral artery is, in that region, but it's not going to give me the cross flow. And for myself, when I'm doing any of the upper cervical stuff, upper skull base as well, I want to know what I'm going to sacrifice. And sometimes, it's a small vert and it's encasing, and it's a young person, you can go sacrifice the vert, no problem, and then go and just do the operation, having coffee, you can be relaxed. But if you're going to get an angiogram and there's, it's a reasonable size vert, or that vert, doesn't end, and the other vert ends in pica, for example, I think you want to know about it. I think there's a minimal risk of getting an angio. I think this one, it's touching the vert, but it's not encasing the vert. But a lot of them go more anterior and involve it. And I think those cases, I absolutely will get an angiogram. Sean, what do you think?
Well, in this case, we didn't, because you could see the flow void.
Yeah, you can see it there.
Yeah, but no, if you're right, if it's encasing or there's question, I would absolutely angiogram.
And also, Sean, the thing about it for me, and I'll be the devil's advocate here, is that why not? So the thing about, even though you can see the vert, it's not encasing, it's got a flow void there, but you want to, she's 35, you want to get this all out.
Yeah, sure.
And you're going to get right to the vertebral artery. Wouldn't it be so much nicer for your own mental state and your own cardiac rhythm to go inside there knowing she's got a vert that you could sacrifice if the worst comes to the worst?
That's true.
So I think, if you look, we do a lot of angio stuff, and our risk of complications, Paul and know, is so low. And I think that this case, if you're going to go and do a subtotal resection, she's 75 or 80, Paul's age, you're going to go inside and just do a subtotal resection. But if you want to really do a resection and it's on the vert, I see there's no reason not to get the angiogram. Just to see the collateral circulation, because, the CTAs are great. I love CTAs. We get them all the time. But it still doesn't give me the information that I really, really want.
Mm-hmm. Okay, yeah.
I think, Gavin, you're bringing up an excellent point about the competence of the intracranial circulation and whether or not you can sacrifice that vertebral artery. You're absolutely thinking like a vascular surgeon, not a spine surgeon.
But I do these and I love them. And I said, it's very hard for me. Someone's going to get short. But I do like. And then so I think that it's important to do that. And I think that for younger people particularly, get that angio and then you can go. And you can go, if it's a small vert and it's really you can go sacrifice if you have to. And the other thing that I like, which I've adapted from the cranial practice, is navigation, as you mentioned earlier. I think it's so nice. These days, and Paul's like, Paul started spine navigation. I don't do a case. Even if the acoustic is like 7 centimeters, I will still use navigation to make sure I'm on the correct side. I mean, that's it. I think that in this day and age, navigation should be part of your pants you put on when you go to the OR. And I think Paul agrees with it, Sean agrees with it. So I think in this case, I will not, and I will get it, when I do these cases, I'll do a CT and an MRI and then navigation and fuse them. And, and that helps a lot as well, Sean, tell us what you did.
Yeah, we just did a right kind of C1-2 laminotomy, sort of partial fascectomy there, and then we ultrasounded and saw the tumor is really mostly intradural and then partly extradural. So we kind of opened the dura and debulked the intradural portion. And I did counsel her before that we were going to take the nerve root as the C2 root, and that she would have some numbness, and so that was part of the plan. And really, there was kind of a hole through which the tumor in the dura was exiting, and the root was exiting, and that we sort of followed that out and took the nerve proximal and distal to the tumor, not all in one piece, but debulked it enough to where it could be, safely taken all out with the nerve.
So Sean, how do you close your dura when you catch your nerve?
I use Gore-Tex suture in this case. I think any suture is probably fine, but just with a running stitch. So the actual hole in the dura where the nerve root sleeve was not huge. It's relatively small. But
so Ziya, I actually had, as a physician, I did, and she developed a leak. I closed it nicely, but she still leaked. How do you close that nerve roots? The nerve roots sleeve?
that is actually a challenging area to close in a watertight fashion. Because of the first of all, this whole hole is sizable, and second, it's not a nice circular opening. It tends to be like a T-shaped and odd sort of a spot. I try to patch it if I can. If I can close it primarily, I can. I usually use a 5-proline suture to close it. I think the Gore-Tex suture is probably the best because Sean, when he was with us today, very nice review of CSF leaks and some of the strategies how to minimize the risk of leak. And it turned out that the Gore-Tex sutures are the best ones, if I remember correctly. Sean, correct me if I'm wrong.
Yeah.
But that certainly is quite helpful. But I still use 5-proline suture with typically a pericardial patch, and then rely on Duragen and Tocil and other things to seal it off. And then we bring the muscle over that area, make sure that it is closed in a watertight fashion, and then the dead space is eliminated.
Yeah, the one I had didn't leak through the skin, but she had a little pseudomeningocele, and it took 6 months to heal, but it did heal with Diamox in it. But I was tempted to go back. She was an endocrinologist, but I ended up healing. But I sutured it closed, but I think I was not suspecting a leak, but you do get them if you don't, if you don't like it.
Yeah, I think you mentioned Ziya, bovine pericardium. There's all these new grafts and things that you can dura repair and so forth, but throughout the last 20 years of practicing, I haven't found anything that's better than bovine pericardium. I just think that it handles well, and you can stitch it. I just think that for me, that's my go-to graft.
No, I agree with you. I like it. So the question I'm going to ask you, for the big dumbbells, so there's big anterior component, big posterior component. How are you going to approach that? Back, front, together, same day? How are you going to do that one?
Yeah, so I found that we can do a lot from the back. So I typically start from the back, and I do as much as I can from the back, and then I re-image the patient and see what's left behind. And sometimes if there is a little lump left more ventrally, I monitor that. Sometimes they involute. If you devascularize the tumor significantly enough, they get smaller. But I always start from the back and then come back from the front if necessary.
And this tumor is on C2, so you can sort of easily take the root. It's the clinical consequences are minimal. But what if say it was on C6 or C7? What do you counsel the patient that your plan is to try to?
So I tell them that there's definitely risk of that they could be left with weakness in the muscle that is innervated that particular nerve root. If it is proximal to the dorsal root ganglion, typically you would be able to separate the tumor. If it is at the root ganglion level or distal to that, then it's hard to separate the motor root. Sometimes the motor root is the origin of the tumor. In those cases, you need to be prepared about there's, I think, overall 7% risk of being left with a significant motor deficit if you were to take the motor root that is the origin of the tumor. And so you need to be prepared.
My experience is, or maybe it's pure luck, most of mine have been sensory roots. Sean?
Yeah, I think that's the most common.
Yours, Paul?
Most are. Agreed.
Do you use stimulation intraoperatively to determine whether or not to ligate the root?
I do. I don't know what to make of it, to be honest with you. I do stimulate. I think the key is to make sure that you are completely isolating the rootlet that you're stimulating. Sometimes that could be difficult. There's current spread There are cases where stimulated gut responses cut the nerve root and the patient did not have any deficit. So I'm not sure how to interpret the results, but we do stimulate it. If you don't get any responses, obviously it's very comforting to be able to cut the root.
Yeah.
Great, thanks. Good case, Sean.
What about, I'm sorry, one more
No,
question. What
no.
about instrumentation and dumbbell tumors? If you're removing a whole facet, or when do you ever consider using?
I have a very, very low threshold to instrument them.
Yeah.
So the exposure I need to get the tumor out and then fix the spine afterwards. Instrumenting the mid-cervical spine several levels, I think the morbidity is quite acceptable.
Paul, what is your feeling about that?
Agreed.
Yeah. Okay.
I'll disagree, but that's my point. Okay.
Yeah, and I think if you're gonna, if you think about it and you think that it's something that might cause, chronic pain, it's just so painful to go back and fuse someone afterwards, as opposed to just doing it right
So
off
if
the
you
bat.
say, okay, this one, you're not going to do occipital cervical fusion.
C1 too, yeah.
Yeah, that's pretty morbid.
I mean, I recently did a case out a couple of years ago at C123. I took the C1 ring, C2 lamina, and half of the C3 on one side, and resected a tumor, a schwannoma. That did not instrument the patient. I said I can get away with it. Then the patient developed significant C2-3 instability with angulations. I had to go back and do a 360 fusion. Did an anterior C2-3 inner body, went back and fused her from C1 to C3 afterwards. That was very painful. As Paul said, I think it's best to avoid the problem.
But the problem is like something like this. I mean, you're going to do, it depends how much of a set you're going to take and how far lateral and how far anterior you're going to go. The other approach we have is that I think the bigger the tumor, the smaller the opening needs to be. And I think that sometimes you can work, obviously you want to get your exposure both lateral and medial, particularly the nerve roots, but you don't have to do all that massive bone exposure, particularly for the large tumor. Obviously, if it's bulging and complete, the facet's gone, I agree, fuse. But I mean, otherwise,
No, I agree. I agree with that. The other thing is, of course, whether the tumor is ventrally situated or dorsally situated.
Exactly.
Dorsal to the cord, it's you can definitely do a much smaller exposure. If it's ventral to the cord, then and I think I like to have a bigger exposure. I want to be able to get above and below the tumor, cut the dentate, rotate the cord, and I think it makes the operation safer in my hands. But
no,
there are people.
okay. But not the universal fuse. Like full fuse. I got to be the intellectual, okay?
Well, I think that's all from my. I think
Okay,
Paul has a
Paul,
case.
you got a case?
Yeah, I was just going to show a quick case here. Yeah, so this was a 25-year young gentleman, just graduated from college in the greatest occupation, which Dr. Britz's son is now in finance, much smarter than people going to medical school still. But this guy is he's active. He likes to work out, and basically he just over the past 3 months or so started noticing some non-specific back pain, particularly after working out, and some tightness in his buttock, and it was resistant to anti-inflammatories, and saw his primary care doctor visiting from New York, and so they decided to get an MRI scan. So you can see here, this is an intradural lumbar tumor, homogeneously contrast enhancing behind the L3 vertebral body. Neurological exam, he had maybe some trace weakness in one extensor hallucis longus, reflexes intact, no sensory deficit, and so discuss.
Well, you know this case, so
for treatment.
Yeah,
so
he probably knows this case. So Ziya,
no, he does not know this case.
Okay. Sean, what do you think?
Well, the intradural extramedullary tumor in the lumbar spine.
Electromedullary, it's not even near the spinal cord, it's way below it, Sean. My teaching never stopped, Ziya. Carry on.
So most common thought would be schwannoma, myxopapillary ependymoma would be the top two, or paraganglioma rarely. I think I've seen. Paul told me about this case. It's much more rare than that, but I typically would shoot for an open, resection, intradural exploration, and I would stimulate the nerve, like we discussed previously, to see if it was a schwannoma, if the nerve could be sacrificed and the tumor removed on block, or if it's coming off of the phylum. presumed mix of papillary ependymoma would remove it, hopefully on block. But
That's too. It doesn't look like a myxopapillary tumor.
yeah.
What do you think, Ziya?
Yeah, I mean, I think schwannoma is the best diagnosis, but mixed papillary meningioma, paraganglioma, all of those are other diagnoses.
Yeah, so we touched a little bit on neuromonitoring. So obviously you're going to monitor this case and stimulate.
Okay, so I'm going to interrupt Paul for a second. Okay? I really want you to concentrate on the word neuromonitoring because I'm going to be torturing for a second. Okay, carry on. He knows.
Yeah, so obviously the one thing about neuromonitoring is that in the past 20 years we have some more sophisticated things, but still the information, as you mentioned, can be misleading in terms of current spread and so forth. But obviously it's a must for this type of case. I'm sure you guys are using it, but now they have the urinary catheters where you can monitor. So I think that's in terms of just being super confident, I think that's been a nice addition in terms of what's available. So obviously we operated on this gentleman, given the fact that even though he didn't have any neurological deficits, it's a large tumor, and we were able to expose the tumor. Didn't really see a definitive nerve root going into the tumor per se, but essentially remove this on block. And kind of right at the very end, we were just kind of mobilizing and then got a little bit of a puncture into the capsule, and there was some clear fluid inside of it, which was kind of an interesting thing. And it's
more likely schwannoma.
This was the surprising finding of this case. So this turned out to be a clear cell meningioma in the lumbar spine. So there was no dural attachment. So apparently there's been 200 or 300 of these reported, and they do typically occur in the lumbar spine in younger people. And unfortunately, this is considered kind of like a grade 2 in terms of aggressiveness, and there's a much higher chance for a recurrence. And so we got this report back from pathology, and we don't have a postoperative MRI scan yet. We're going to get one in 6 months' time. But this is a very interesting case. I just wondered, Ziya, if you had seen one of these clear cell meningiomas in the lumbar spine.
I have not. I've seen meningiomas, but in younger people, I've seen meningiomas in the lumbar spine. That's why it's sort of included in the diagnosis. Sometimes you see that, but I haven't seen the clear cell version of it in the lumbar spine. I've seen it in the upper thoracic spine, and they tend to be more aggressive. They tend to recur more often. And I'm glad that you got unblocked resection of the tumor. Hopefully, that would be the end of it for.
So, Paul, where was the origin from?
That's the thing. No one really knows what the origin is because it's a meningioma.
So it wasn't attached to the dura.
No. There's that. That is the kind of peculiar thing.
Because obviously meningiomas come from arachnoid cap cells.
Yeah.
And arachnoid cap cells can follow the subarachnoid space. So that's probably what it originated.
I'm sure.
So you talk about neuromonitoring. What did you want to talk about that?
I just think that in cases like this, obviously. If you have we thought this was going to be a schwannoma, and sometimes it is frustrating, as Ziya pointed out, where you don't have any nerve roots en passage. You have something that has to be non-functional, and then you are stimulating and wasting time in the OR, right?
And now we're going to talk. Yeah.
Yeah.
I'm going to talk to you. So Ziya, so what's your approach? So obviously, me and Paul we're very good friends, but we're diametrically opposed when it comes to neuromonitoring and how you respond in the OR. So for me, and I'm only 1 or 2 years old. Pardon, what's that?
I love neuromonitoring.
Yeah, so do I. And the thing about what I also say, if you're going to neuromonitor, listen to the results. There's many times, and Ziya, be it a skull-based case or upper cervical tumor, whenever I have not listened to it, I've regretted it, okay? And so when I'm in the OR and Paul's come to me for interrupt consults, what do we do? And I would say, Paul, close up, okay? And then so some of these guys just carry on and carry on. So I'm not going to mention Paul's name. They just carries on and carries on. But I back out.
Yeah.
Say another
I mean,
day,
this is obviously, we're talking about intradural tumors here, but
regardless, even for just
yeah, no, I understand that. I mean, this is a whole different conversation.
No, I want to, yes, Ziya, well, we've got time. We've got 2 minutes to go. Ziya, what is your approach? Do you always back out or sometimes back out, or or you continue to plow ahead? If you get changes in your monitoring.
First of all, let me say this categorically. I'm a firm believer of neuromonitoring. I sometimes get frustrated.
As well.
I agree with Paul that sometimes interpretation of the data can be challenging, but I take it very seriously. I learned over the years that all the changes, if they are not technical, they are real. They are real. And so you need to take them very seriously. With spinal cord tumor surgeries, we use neuromonitoring extensively, including D waves and other things. And we learned that, if you have changes, you need to take them seriously. There's always neurological correlate. If you go back and examine the patient carefully, if there are changes in the OR, you will find what that really resulted in. And you learn from that experience how much you can manipulate the nervus or the spinal cord as a result of that. In the lumbar spine around the cauda equina, for example, you have to be really careful in isolating the structure that you are trying to stimulate, because you're able to see what you're looking at, but the nerves may be touching more distally, and you may be stimulating, you're getting responses. Sometimes you're stimulating the nerves on the right side, getting responses from the left side. We're always getting some responses from the sphincter. And so it could be quite frustrating in terms of trying to make sense of it, but I believe in it.
Yeah, me as well. Yeah, I back out. There's always another day. And in my experience, and I've only done it twice, where I continued, people never got better. And I think sometimes it could be technical, but the way I look at it, and me and Paul, the different opinions, why take a chance? Just back out. And we talk about it, but I do think, I'm glad to have this discussion with Paul, is that unless it's technically that the electrode fell out, it's real.
Yeah.
Like, for example, my acoustic I did last week, half the signals dropped, the most. I knew it was real, and we closed, the tumor was gone. But I still think that if you look carefully enough, you're going to find, and she woke up with a little weakness, 4 out of 5, but it's real. So I think we've got nothing to lose, particularly as we want to push medicine, to the absolute best quality we can have. Listen to the data. If you don't listen to the data, why monitor? So unless you're going to obey those results, don't monitor. And we have many fruitful discussions between the two of us about this. But I think, Sean, what do you think?
I agree with both of you. I don't think either of you are wrong.
You see, he's the junior partner. Okay, he agrees with both of us.
Yeah.
But I'm just saying, I think, though, that that's my feeling.
No, I mean, I think a perfect example of this is, we were very, very early adopters of trans-psoas surgery. Yeah. And, just doing free-running EMGs was not super helpful. But, since we incorporated saphenous SSEPs and motor evoked potentials, you have the opportunity to remove the retractor, collapse the retractor. When you're doing deformity surgery, obviously, it's not something that you're looking at, touching and feeling. It's more about changing the shape of the spine so you can undo your correction. So obviously, I'm a firm believer, and we all have to use neuromonitoring. So Ziya, I'll just one last hypothetical, since we're talking about this. You're doing an intramedullary ependymoma, and I know your technique, right? You've opened, done a big myelotomy. You have your arachnoid clipped up against the dura, and you find a great plane, and you're taking it out. You're going to work towards the final pole of the tumor, and then the neuromonitoring tech says that everything is gone, and you're just about to put an end to the tumor with a clean plane. What would you say, since we're talking about intradural tumors? In that particular case, you're gonna check your mean arterial pressure, maybe drive that up a little bit, but are you gonna stop with taking out an ependymoma?
Yeah, so first of all, we are doing mostly the D waves on those cases as well. So if my MEP is dropped, then I want to make sure that my D waves are still present. If they are present, then we proceed and take the tumor out. If the plane is perfect, then I know that I'm not disturbing the spinal cord, and we are at the later stages of the operation, I take it out and accept the consequences. If we are at the mid portion of the surgical procedure and I'm seeing changes, it doesn't look like I'm causing any problem, I walk away from that area, go to the other side, and start working in a different place. Sometimes that is helpful to establish a better plane. But you're constantly listening to the spinal cord, and I think MEP changes, I take them very seriously. Sensory signals, SSEPs, you may end up losing them at the very beginning of the operation. I don't pay much attention to them. But if the MEPs are also not, always 100% reliable, but if you couple that with the D waves, and if you monitor the D waves as well, I think you'll be more comfortable in proceeding. If you lose everything, then it's obviously
But not even,
very bad.
yeah, that's an extreme. So the most situation is you'll go inside, you open up the cord, you're doing some tumor and you lose one motor, left side, for example. And you, as you say, you go to a different area, you go work on that tumor, try and get it out, and it doesn't get better after doing all the normal stuff. Do you continue or you back out?
If I really truly lost them, it's not coming back, and I back up.
I mean, as well. And that's exactly it. So that's the thing. It says, I think you've got nothing to lose. Me, Sean, I do them with Sean and that, and I think that I mean, that's my approach. And the reason being, and every time we've done it, Sean, they have some weakness and they get better. So I just think that's where. Anyways, while I'm on top and I've got Paul to admit defeat and regarding the monitoring, I think we're going to call it a close. And I really want to appreciate everyone to come. Ziya, you are a very, very busy guy. Paul and Sean, I really appreciate it. I think it was a great discussion. I learned a lot. And thanks very much, Ziya.
Yeah, thank you.
Well, thanks for the opportunity, and I really enjoyed the discussion, and as always, a learning experience. Thank you so much for the opportunity.
Thanks,
Thank you, Ziya.
Bye.
Bye. Bye.